This year's scientific sessions featured a full day of health tech presentations exploring the role of technology on the treatment and prevention of cardiovascular disease. This is really what I call a cover story follow-up on what we called Cardiology's fantastic journey to miniaturization. And I am with Dr. Uday Kumar, who is an MD and a consulting associate professor of bioengineering. And we are talking also to the founder and president and CEO of Element Science and the founder of iRhtyhm Technologies. It was your ZeroPatch that was one of the products featured in our September cover story. So what I want to do is, your session was on identifying needs addressable by digital health solutions, how mHealth will transform the outpatient management of arrhythmia. So take me through what you talked about. And I think you used the ZeroPatch as an example.
Yeah, so consistent with what we teach at the Stanford Biodesign Program, the basic philosophies here: when you want to solve unmet medical needs, focus on the need and not the technology. So much of what happens in the consumer and the outside of the healthcare field is, I have a gadget, I have a smartphone, what can I do with it? And when you're making decisions as an individual, that may work. But in healthcare, really understanding the entire milieu of what goes on in terms of how patients view their own sickness, who are the stakeholders in the environment, from the patient, the physician, the payers, the hospital system, to just the realities of what patients have to go to, particularly as we try to move technologies and methods of diagnosis and treatments out of the hospital. It's actually not so straightforward to just apply technology and hope it works. It's really to focus on understanding everything through observation and a deep dive into all of the things which are core to being good physicians and good healthcare professionals, understanding the disease state, understanding what's the landscape of the products out there, understanding who's affected, who's not, understanding who's the target population, understanding what you need to show to provide good clinical evidence. And everything I'm talking about is just understanding the problem. Once you have a good understanding of the problem, then digital health, mHealth, wearables, or whatever other buzzword you want, just gets put into the pantheon of potential solutions as another tool to use. So I think the fundamental premise of what I see is been a challenge for digital health is an application of a more tech mindset, as opposed to the kind of perhaps a better way of looking at it, which is what we do at Stanford Biodesign, of taking physicians and engineers and putting them together to kind of understand clinical context of important issues to solve, and then pulling from the toolbox, of which some things may be digital health and maybe not. There's a lot of probably things we could solve with behavior change and other things which have nothing to do with technology, but we assume since you have a hammer, we should use it.
Yeah, absolutely. And with the technology, a lot of it seems to get handed down from on high, the idea of bringing doctors and engineers together to try and even out this process so that it is workable at the clinical end when you're done with it.
Right.
That's really important.
Yeah, and actually it's also, as physicians, or as a patient, you don't want your physicians to be creative. you want them to really do something pretty well and know exactly what they're doing. But that also makes it hard to imagine how things could be done differently, because you're biased, and and creativity in medicine is not those are not necessarily words that go hand in hand. That being said, when you bring into a clinical environment from an observation and like a real ethnographic approach or design thinking approach, you get people who may have never seen something, and so they're not limited by what's possible or what's not possible. So when you have someone who kind of understands clinical medicine and the clinical healthcare sphere, take a little bit of a step back, and then have someone or other people come in with a much more open mindset, together they may lead to something that's actually solves a clinical problem, but in a way that's very different.
And that kind of is where you brought in the ZeroPatch, correct?
That's a great example. So I'm a cardiologist and EP by training, but I was also a Stanford Biodesign fellow myself years ago. And we focus on the field of cardiac electrophysiology and what are unmet medical needs. And one of the observations we had is when people present with very, common but vague symptoms like palpitations or lightheadedness, these things come and go. And so when they typically, if they don't have a cardiologist, which many people don't, but that's their first presentation, they go tell their doctor, their primary. Primary says, oh, that's fine, you look fine now, and but let's focus on your back pain or knee pain or head pain or whatever else it might be.
Exactly.
So these things continue to happen and patients aren't diagnosed. Ultimately, they may have a more severe presentation where they go to the ER, but again, ERs aren't, if you're out of it at the time you get there, what are you going to do? So as we track the patient flow, it's amazing how many times it took to finally get a person to a test to make a diagnosis. And sometimes they have to go up the value chain to get to a cardiologist who would prescribe a test. And then the most common test prescribed, a Holter, is only for 24, 40 hours when most arrhythmias happen much less frequently than that. Correct. So when you think about the entire workflow, the patient experience, the number of tests, because if the Holter is negative, you get something else. the entire cost and time was astronomical, and it seemed like this is just taking an EKG. We should be able to do that much more simply. So that led to a focus on a better way to detect suspected arrhythmias in non-hospitalized patients, to improve the patient experience and to reduce costs. That was really our need statement for that underlie the ZeroPatch. So as we started then brainstorming and looking across the toolbox of technologies, patches were really big back in the 2005 and 6 and 7, but it seemed like, hey, if you could stick something for up to 2 weeks, which is at least seemingly where you'll capture most arrhythmias, right, and do it in a way that the patients don't have to interact with it, or it's much more that it integrates into their lives. That patients really cared about the fact that they didn't want anyone knowing that they were being monitored. So a wire coming out to something on your belt
wasn't going to work.
And then again, and I think the healthcare system, we assume as physicians when we write a prescription or tell a patient to do something, they'll do it. And not for bad intentions. Life is hard, and patients who have sickness and they have multiple jobs and they have caregivers to children and elderly people, and socioeconomically they don't have time to exercise and do all these other things. It gets difficult to then say, go to that lab to get the device, and when you're done, bring it back, but I'm feeling fine now. So all of these things limit the ability to get timely diagnosis. So we realized you can't have these reusable devices that have to be tracked and everything. So the ZeroPatch is a single-use device that gets applied at the point of care. The goal was, over time, it can be deployed from an ER, from a primary, to start the process so that you can really rule in an arrhythmia, and most arrhythmias have a treatment paradigm, or rule it out and focus on something else and give some peace of mind. That's what patients want. They want to be able to get an answer to their question. So by really focusing on what the patients want, we came up with the ZeroPatch. But that was only one part of the equation. Because another thing we do a lot at Stanford Biodesign is talk about stakeholders. So the other stakeholder in all this is the physician. Well, at least at the point of prescription. But they're less concerned about, and unfortunately or fortunately, whichever way you want to think, about the experience of the patient, but they really care about what did we find.
Yes.
So we spent a lot of time thinking about, well, how are we going to make sure that if we order one test, it will have the information at a level that an internist or an ER physician can quickly understand, does this need to be triaged up or not? And if an EP gets it, it has all the information that they need to potentially plan an ablation without having to order another test, because that's just a waste of healthcare resources. So we spent a lot of time thinking about how do we present that information in a very novel reporting format, but then also how do you sort through 14 days of every heartbeat? No one ever done that. So again, going back to the toolbox, we realized for that we needed another very high-tech solution. So we developed a very sophisticated cloud-based analytics platform that goes through a lot of the data, for which we can then quickly look at what's important to present the right clinical findings to the physician. And so that whole system was really a solution. So when we looked at the problem, it wasn't the patch, it wasn't the algorithm, it wasn't the service, it's everything. So iRhtyhm is really the way I look at an IT company enabled by a novel device, supported by service. But that's how you solve the problem.
Right.
And I think a lot of things in digital health have not necessarily taken that holistic view. They've either focused on the hardware or the software or the service, and most importantly, not focused on why and what are you trying to accomplish. And maybe the last thing I'll add is it's also, we have the ability today with technology to do a lot of things. The real question is, what do we do and what do we not do? Because again, as you start adding features and other things, it adds cost and adds complexity. And sometimes then that starts veering you off what's really necessary. So the ZeroPatch is great for most patients, but if you have a very, very high-risk patient who could drop dead, that's not the right product. You need something else. But for most others, you don't. So we also have to change the healthcare environment in the US to really make sure that products are aligned to the problem and the answer you need, not any answer you can potentially get.
So how did you conclude your session? What was your bottom line that you wanted people to take away?
Well, yeah, from the morning session, it was basically, when you're thinking about how to identify needs that potentially might have a digital health solution, put the digital health part aside for a moment and focus on the problem you're thinking about. Go through all of the things, like I mentioned before, about understanding disease state, the clinical landscape and everything else, and importantly patients, because digital health, we're really talking about things that physicians use as one stakeholder and patients will then have to adopt in wearables as well. Focus on that, and then go see if a digital health solution from a smartphone or an app or wearable is the correct or not correct. And surprisingly, oftentimes it turns out when you actually go through this process very rigorously and rationally, you come up with better digital health solutions that you might have thought about. And in other cases, you realize, hey, it actually has nothing to do with technology. It's more of a process change or a way healthcare is delivered. And so the bottom line is, don't get enamored by gadgets. And I'm an EP saying that.
No, I think that's an excellent point. And in CardioSource World News, we have been for some time making sure that you are up to date on the various digital aspects of life as a physician. We're going to continue that, and please, for the rest of the coverage from AHA, please look around here online and also in CardioSource World News, where I'm Executive Editor Rick McGuire.